Welcome to Fostering Parenthood.
Consent.
Porn.
Normal relationship.
Being a teen mom.
My first real adult love.
What it's like to be a foster child.
Every person I had an attachment with had left.
How trauma impacts your decision making.
I didn't feel very accepted and I didn't feel very safe.
And he said, you are lowering your own value by putting up with this.
And I wish someone was there to be there and tell me that it wasn't okay.
How do I honor providing that space for them?
It's about being in a place to be open to someone sharing with you their hurts.
Making sure that you guys are going into things open and supportive, or just even willing, right, to have these conversations.
I need you to find the strength to call someone and say, I'm drowning right now.
It's helpful to know yourself first as a caregiver.
But I just want caregivers to know that you're not alone.
You called me mom. Welcome to Fostering Parenthood, where we explore the challenges and triumphs of parenting youth in care. Today, we're exploring an important topic that affects many youth in care, their mental health. We'll be discussing how caregivers can support the mental health of these youth, access Medi-Cal mental health services, and advocate for their youth. Our guest today is Nancy Netherland, Director of Parent and Caregiver Engagement. She's a mother of two, both former foster children living with rare, chronic, medical complexities. She founded Kids and Caregivers, a nonprofit supporting families, caregivers, and providers of chronically ill children through wellness and navigation resources, coaching, and peer-based activities. Nancy has extensive professional experience with the healthcare safety net and has worked as a consultant with public health, community and school-based health centers, as well as served on a variety of committees, including the State of California's Medicaid Children's Health Advisory Panel, and more. So whether you're a caregiver of a youth in foster care, a healthcare provider, or simply interested in learning more about this important topic, stay tuned. This episode promises to offer valuable advice and lessons learned on how caregivers can support both the mental and sexual reproductive health journeys of youth in care. Thank you, Nancy, for joining me today on this podcast. I am so anxious to talk to you and just get in your head, because I know that I'm not the only caregiver out there that needs this vital information about mental wellness and the services available as foster parents for our foster children. Could you do me a favor and start out by just sharing with me a little bit about your background and why did you get into this field? What's interesting to you about it?
Sure, I'd love to. And I'm also delighted to be here today. And I always relish an opportunity to talk to others who share my passion. So I think I always knew that I wanted to be a foster parent. Like my family talks about me talking about wanting to adopt and wanting to build family in a really different kind of way than we might traditionally think of as kids. So as I came into adulthood, I ended up studying psychology and counseling and art therapy, and had an opportunity to work with folks who were living on the streets and who were unhoused. And that really just renewed my interest in behavioral health and also really kind of systems of care. I was fortunate enough to meet and marry my husband, who also had always wanted to build his family through foster care. So it was one of those things. We met each other, we fell in love, and then we realized we had the same goals for building our family. And so, as a multiracial family, he's African American. We also were really fortunate in that there was at least in California, a shortage of multiracial families. And so we were really open and excited to parenting, and we basically didn't have a lot of ideas about who we wanted to parent. So we really just said, whoever, here's our profile. We lived in San Francisco. We're happy to parent whoever needs a home. And as luck would have it, we got placed with an infant who was medically fragile and who needed a lot of care. And we were delighted to give her that care. And really, I can't tell you how magical it was. I'll never forget meeting her. She was in a receiving home, and I picked her up and she looked up at me and she put her little hand on my face and looked into my eyes, even though they say she was too young to look into my eyes. But she definitely looked into my eyes in some way.
Absolutely. Don't let them tell you that.
Right? And it was for everyone in the room, like the social worker and everyone was like, that baby and you connected. And we did. And it was like finding a piece of my heart outside of myself. And I said, yeah, this is it. And they said that while we were there, some test results came back showing that she had hepatitis C and a few other things going on that were pretty serious. And I was like, our spirit's connected. This is my baby to take care of for now. And that's how it all started.
Wow. I'm sorry, but I have chills all over my body. When you know, you know.
Yeah.
And your daughter is blessed to have you. And I know that you probably rejoice every single day of her life with you.
I do. And I feel like I always say to people, like, I am the lucky one. Do you know, like I absolutely feel completely lucky. And so I think I may have shared this with you. We started out fostering and then eventually adopted and then adopted a sibling group. So I have 2 girls who are 15 and 16. And both came, Amelia, her sister. So Sarah's my oldest. And Amelia, when they called us, they said, Sarah's got a sister and we don't know what's going to happen. And we think that she was in the NICU. She was born very prematurely. She needs to withdraw from opiates. And we think that she may be blind and mentally retarded. And I was like, okay. Let's bring
go,
her
girl.
home. And what I knew, right? Because as we know, when we foster, like, we get to love our kids for as long as we get to love them. And we don't know what the outcome's going to be. Like, we don't know if they're going to get back with their family or what's going to happen. And I was like, I can love this kid as long as I get to love her. And then I'll figure out the rest from there. So that was 15 years ago. And we ended up doing that. And then since that time, we've done some different kinship care. So we've always had a household with my 2 girls. And then we've usually had some older kids or some teens who've been with us as well. So
yeah, teens bring a whole different element, don't they?
They do in young adults.
Sure. Yeah.
So
the newborns that we bring home from the NICU have an entire different, just group of issues, right? Or things that we get to partake in. And then we have teens that often, these kids grow up, darn it. They don't stay these little 6-month-old babies that coo and smile at us and connect. And yet finding a way to connect and to meet the needs of a teen is so vitally important.
Right.
What's the trick? I mean, when it comes, I have kiddos in my home and have over the years who have very specific needs, mental health needs. And oftentimes what I find is that the diagnosis doesn't necessarily come with the child. In other words, I'm finding that doctors are leery to provide a diagnosis for kids simply because they're adolescents, they're children, and they're not adults. And so treating something, and I'm not into labels, don't get me wrong, it's just sometimes it seems like you're kind of floating out there because you know that there's something going on. You know that you need to get help, but without kind of that guiding light of what this condition might look like, whether it's schizophrenia, bipolar, all of these different issues that a lot of our kiddos start to show very strong symptoms at a young age, meaning early adolescence. I hate the fact that our system wants to wait until they're 18 to really identify and attack it. How can we support caregivers who have these kiddos who they believe their child perhaps has, besides trauma, because all of our children in care have trauma. So now you have a child who has trauma, but also perhaps has another mental health condition. What is your advice on how to get those services, how to navigate the system, because it's a huge system.
It is huge, and can be punishing actually at times. So I think, some of this is going to be really fundamental, but be observant and take notes, keep logs. I think that it's really challenging. So I think the problem about not having labels or not having diagnoses is we also don't get services and treatment. And I feel for my kids and every kid who's been in my household that they have a fundamental right to have access to care. And if that means that I need to push for a diagnosis, then I'm going to, because it's a lot harder. I mean, to use an analogy, it's a lot harder to put the toothpaste back in the tube than it is to put the lid on it partway through. And I think with mental health issues, we know that the further they progress, the more intractable they become, and the bigger burden there is on the young person to work on their recovery. So I knew, and I think many of us know, when we bring our kids home, there is a lot of trauma. And we know with trauma, there can be increased. Now, I also want to say, I think that my kids and many of the kids I've had the pleasure of caring for or spending time with are incredibly resilient and have enormous amounts of assets. And I mean, are fundamentally quite remarkable in that regard. And I also think that it's important to note where things are not quite tracking and not working and to really note it. So I do a both and. I focus on the wins, but I'm also really diligent about tracking and noting what's not going well, specifically with the idea that my kids should get care as soon as possible, and I shouldn't have to wait for them to walk off a cliff. So we know that kids who come out of care have a higher trauma load, which puts them at risk, even with all the assets and the resiliency, for behavioral health issues and substance use disorders. And there may be some familial biohistory, and we know that epigenetics, and a lot of things go into basically what creates our propensity or our predisposition to have different types of conditions. So I use that, and I'm really strong about saying that when we see providers. I'll say, we all know that we don't quite know what creates the risk factors, but we know the following do put our kids more at risk. So I'm going to ask that we really don't dismiss things. The other thing I do is I use a lot of data. So my kids are mixed race, African American and European American. And what I know is that kids like mine are underdiagnosed, and their conditions are often dismissed as acting out, being defiant. We see disproportionate numbers of African American kids living in Black and brown bodies diagnosed with oppositional defiancy disorder instead of anxiety, instead of autism, instead of ADHD. Dr. Amanda Calhoun does some brilliant work on this. So I arm myself with the data. And one of the things I do is I invite everyone in my kids' system of care, which I'll talk about. It's pretty vast, but I invite people to help me help my kids not fall into patterns that have harmed kids in the past. And so I'll say things like, I'm concerned that my daughter may have a form of sensory processing disorder that's looking like oppositional defiance. And I know that you want to support her in not falling into a trend that's been a part of our history, where kids who look like her, who are Black, who end up getting diagnosed or misdiagnosed or not diagnosed, right? And they get put into like a disciplinary thing versus a treatment thing. So one of the things that I do is I always invite looking beyond kind of some of the stereotypes. And I think when people hear foster youth, unfortunately, I sometimes want to go into providers and not say that my kids came out of care or that the child with me is not in foster care, because I think that there is this kind of assumption. And I think that, I find that really problematic. So I've learned some ways to really literally articulate and help differentiate. I was just talking about this with a friend today. I was saying, I think one of the keys to navigating the system is learning how to talk about differential diagnoses. And I hate the idea that we have to diagnose, but I think it's important that we differentiate a kid who's suffering and who's struggling from a kid who is quote unquote acting out or being defiant, because it's a very different response. So part of what I do is I invite providers to look for where my child might be struggling or suffering versus, being non-compliant or failing in school. So that's a piece of it. There's also a bunch of logistical stuff that I do as well, because the system, unfortunately, behavioral health care is really quite divided, right? So if your child has mild to moderate kind of conditions, that might be treated in primary care. If they have greater needs, it might go to specialty mental health, right? And in California, that goes into county, it's through county mental health, right? And that's a whole different thing. And there's kind of this vast divide between what happens above the head and what happens below the head. And I think as caregivers, one of the things we get to do is we get to create a bridge for our kids, and we get to hold a space of unity so that neither side forgets that this is a child that's got a complex and holistic approach to their life. So I feel like I often create a bridge to bring my child's behavioral health providers into the medical world, and then vice versa, because I know that my kids' health conditions absolutely impact their psychological wellness. And not just my kids, all kids, right?
All kids, right. Yeah, well, it does with us as well, right? How we're feeling.
100%.
Often, it dictates how we're going to act that day, right? You're not feeling well, you're not going to act well because you just simply are not as tolerant, right? We just don't see the world through those kind of rose-colored glasses. We're focused on the pain we're in, whether that's emotional pain or physical pain. And we really do need to build that bridge so that our kids can get that more holistic approach. I'm curious, if you were to go into a doctor with one of your children and you had concerns and you wanted to keep them off of the behavioral track, even though the outward signs of even if you journal, it's going to say those outward signs, right? Whatever, talking back, spitting, kicking, whatever those signs are. How do you keep them on that medical approach? How do you keep them, logistically, from going there? And I love what you said already about making sure, and sometimes not even mentioning foster care, because it does immediately turn the tab of that book to problem child, right?
100%.
This child's been in the system. This is we're not even going to go down any other road. We're going to start treating behavior. Right.
We make an assumption. There's still stigma, unfortunately, right? There's a lot. I think there's a lot of opportunity to help providers unlearn the biases that our culture holds. So that's what I assume. Like, I assume there are no bad players. Sometimes it's harder than other days. But I have an example. So I have one of my daughters, and she's given me permission, by the way. Anything I share, my kids explicitly we review before I ever share it publicly, which is very important for me to let you know that consent is a big part of how I tell stories about my kids. But my daughter's given me permission to share this. So in the last month, we went in to see a gastroenterologist. She's got a history of IBD and Crohn's, and she also has a history of anxiety. And she's had increased this is a new test doctor, and she has had increasing symptoms of like weight loss and increasing stomach pain and a bunch of other things. And it was one of the first times in a really long time this happened. But he's new to us, and he looked at the file and he was like, former foster kid, teenager, history of anxiety. And he was like, well, I think your pain is probably, from anxiety. And I was kind of like, pretty sure it's not. And I said, I just want to assure you that her anxiety is, I'm very proud of her. She's done an amazing job managing her anxiety. She's taking part in her therapy program. She's doing equine therapy. She's doing all the things. Like, she's remarkable. And her anxiety is not an issue. Now, he didn't ask, right? Good place to start. So I said, since we didn't have an opportunity to talk about this, I want to let you know that Amelia's anxiety is extremely well managed. In fact, she just did a whatever inventory, and it shows that, her psychologist feels like there's nothing here to see right now. Like, she is in remission. And he said, well, 15-year-old girls in stomach pain, it's, it's often anxiety or depression. I said, or it could be that she's got a history of Crohn's disease, And so I really pushed back, because I know my kid.
Yeah.
And I said, and he said, and teenage girls, they like to be skinny. And I said, she's been on a feeding tube because she can't digest food. I said, this is not liking to be skinny. And I said, I appreciate your training, and I appreciate that this may be the case for the majority of young people, but I'd like to invite a different framing of what's happening. Now, that doesn't always work, but I'm really upfront. I'll say, and I said, I wonder if you could just humor me by giving me a differential. Like, how would we know if this is actually a flare-up of her IBD versus, a flare-up of her anxiety that's unrecognized by her psychologist? I'm just, I'm curious. So I ask a lot of questions because I also know my kids pretty well, and I listen to them. My children, I know when I know when they're struggling. Here's the other thing. I believe their narratives. I think it's important to believe the narratives of young people. And I think when a young person says, I'm in pain, that we listen to that. We listen to that. Until
and it's
proven
so
otherwise.
important, right? I mean, it's the foundation of everything. I mean, if every time they open their mouth, we don't hear them, they're going to stop telling us.
100%. Yeah. So I think that's a big piece of what I do. I also strategically try to amplify when I may be misusing it, but there's a term around emergent strategy where we can use our privilege and act as allies to kind of push back on systems to create space to make sure narratives are heard. And so one of the things that I try to do is use my privilege as an adult and as someone who's a little familiar with the healthcare system to try to make sure that my kids' narrative is centered. So if they're talking about, I really think it's important when our kids say they hurt physically, that we don't just assume that it's an emotional causation. Now, it could be totally open to that, but I always ask for the reason why not. How do you know that this is not something else? And I do the same thing with neurodivergency too. Right? I'm always very curious about how do we know, like, why are we assuming this is a behavioral problem? Have we ruled out? And just, I always will say, I just am curious and want to know and understand, like, how we've ruled this out from being something like ADHD or sensory processing disorder, and really not holding kids accountable for things that they may have no volition over.
Absolutely. Oh my gosh. I love what you're saying is just so, my gosh, it's so important because so many of our kids they're put aside, well, this is happening because we know, you don't know, we know, and we don't know. We don't know. We don't know what's going on in these kiddos' minds and in their bodies. And the only way we're going to know is when they share it with us. But if every time we take them to the doctor or a specialist and they immediately put it on the label of teenager, depression, this is normal, have a good life, all we're doing is telling our children that they don't have a voice, that when they use it, no one listens to them anyway. And that's when we do start getting depression, right? Because now we have kids that are going, wow, I really have stomach pain. And they're telling me it's in my head. No, it's in my stomach.
Right.
Right?
Yeah. And so maybe, I also think we obviously as a family, because we've got kids with medical complexities, use the medical system a lot, but I also think there may be other places to support the psychological well-being of our kids that are less medicalized. So I think that some schools, especially in California, have remarkably strong behavioral health programs for kids. What I love about those programs is I feel like there are ranges sometimes with everything from trained peer counselors. So young people teens love their peers, right? And
they do.
I was lucky enough to be a teen peer counselor. And I just remember how relevant it was to my peers and for me too, to talk to peers. So I think sometimes too, part of what I advocate for is looking for those places that feel good to my kid and feel validating. So this continuum of school-based health, and I know not everyone has this, but the continuum of kind of school-based behavioral health, which in California there's a bunch of funding being increased, and we're seeing more peer professionals and wellness coaches, and then of course school psychologists. I think that holds a lot of promise because I feel like there's a form of youth development with behavioral health expertise that lets people hear our kids in a different way. And my kids will tell you, like, they'll raise their hands first off and say, we'd way rather go see a school counselor or a school psychologist than someone from the doctor's office. And I think it has to do with, first of all, they're more comfortable. They're at school. And they don't even like school that much. So it's not like school's super comfortable, but it's more comfortable than the medical setting as a teenager.
Well, that says a lot.
Yeah. And then I also think that there's a different way of listening. I think that some of the school-based providers are really less pathologizing. So I also want to say one thing that's changed in California that I think is super important is we now have presumptive eligibility. So we don't have to wait for our kids to have diagnoses to get them care. And I think that's a really important thing to know.
So important.
Yeah. So when I started my journey.
Say that again, girl, because that is one of the key pieces that we're finally at this
Yeah.
point. So if you could
So we
share.
have a right to our kids have a right to presumptive eligibility. If we think they've been exposed to trauma, that's enough of a trigger at this point. If they're kids of color. So, and there's a bunch of other things. If they've been in the foster or child welfare systems. So what that means is you don't have to have a diagnosis to get care, and you don't have to have a diagnosis for your kid to advocate for care. I also wanted, so back when I started this, my husband, the girl's dad, ended up getting really sick. And so I was like, and we knew that he wasn't going to be around for terribly much longer. So I wanted to get care for my family because it was like double loss, like, right? Like losing your birth parents and then losing your dad. So I remember going to the doctor and saying, okay, like I want to sign up. First of all, like I want to get my kids into the program because we know that they're really at risk. Like this is double trouble. Like they have medical conditions. They were in care and now their dad is really sick. And she's like, oh, we have to wait till they have diagnoses. Like that was Medi-Cal then. Medi-Cal now, we don't have to wait. We don't have to watch our kids fall off the cliff. So as caregivers, we can advocate for our kids to get care without a diagnosis. You can, it's called presumptive eligibility. For our kids specifically, there's something called the 1915B waiver. And that means if our kids need specialty mental health care, if you're caregiving any child who's been impacted by foster care, in care, adopted through care, whatever it is, they have a right under the 1915B waiver for eligibility for specialty mental health services. So you don't have to go through the whole big assessment. You don't have to wait for the big florid diagnoses. Those are some benefits that are newer in California. And I know that there are benefits elsewhere in other states. I don't track the Medi-Cal reform landscape as well as I should in other places, but there are these types of things to look for and they really make a difference. And so now sometimes I'm educating my providers. Sometimes I'll say, I've in the last 4 months, I've had an opportunity to talk to primary care providers and say, hey, let me tell you about presumptive eligibility. Here's that. I've had a chance to say to county mental health, hey, did you know that there's a 1915B waiver? And this means that as a former foster youth, wraparound services and other things are on the docket for my kid. So I think I feel like that's language of empowerment that's super helpful. It's been helpful for me.
Yeah, and I can definitely see that. So we know that with presumptive eligibility that our kids now can get care without a diagnosis. In other words, you don't have to wait for that bipolar or that ODD or whatever that looks like. If you have concerns, you have the right to have mental health services covered by Medi-Cal.
That's right.
So, right. So where do they go? Because I have a lot of caregivers that say, I know I've got Medi-Cal, but I can't find a provider that takes Medi-Cal. Where is the best place for them to go to get mental health services?
That's a great question. So there are tons of shortages, as we know. So I think it's a kind of a tripart answer. So if it's mild to moderate, like you think like maybe anxiety, depression, primary care providers or adolescent health clinics. So FQHCs, wherever you're getting your behavioral health, or wherever you're getting your primary care. So, and there are a lot of really interesting programs that are happening now where there are things like telepsychiatry or telepsychology support so that primary care doctors have a little bit more support. There are some things, I'm just going to put it out there because I do a lot of policy work. Right now, there's some policies that make it hard for community health centers to bill a behavioral health and a primary health care visit on the same day. But there are a bunch of us working to change that. California Primary Care Association and a bunch of us advocates are on that. But you can ask your doctor. So ask primary care. And I think it's important to differentiate between specialty mental health and kind of more mild to moderate. And most of our young people, before they're going to hit specialty mental health, will spend some time in the mild to moderate. That means getting some counseling. That may be getting some psychosocial education on ages and stages. That may be some telehealth. So that's one way to do it. Now there's still shortages and it's tough. School-based health centers, SBAC, did I say that right? School-based health association. Anyway, there's a association of school-based health centers. You can Google it and you can look for health centers in your area. Now, I will tell you something. My daughter desperately needed a counselor, and there were none available through her primary care. But school-based health centers don't just serve the kids at that school. So I called a local school-based health center and figured out what I needed to do to get a referral in. So they had a lot of really robust behavioral health providers at the school-based health center in the town, like the city next to us. And so
that's great information.
So that's another one. And then there's a kind of another piece. If our kids have I think it has to be a medical necessity, if they need something more. I mean, you can also ask for a referral to psychiatry. So if you think your child needs medication and it can't be managed in the primary care setting, you can either ask if the primary care provider has access to a telepsychiatry consult where they pull someone in if they're not comfortable doing it alone to help your child stay in that same environment, or if you can get a referral. And I've been told so many times there are no referrals available for psychiatry. And I have one of my kiddos needed some ADHD meds and they didn't want to do it in the primary care setting. So I just called back I'm relentless. I have my calendar. I called back every 2 weeks. And sometimes it takes me months, but eventually I get to know the schedule really well. And I'll say like, is there any, like, if I wanted to do this, how would I do this? And I also will say things like, I'll say to the scheduler, like, I know that you're a messenger, but here's the situation. This is a young person who, and I talk about the background of my kids and why it's so important for me to advocate. I also do this for other kids because I kind of love doing it. I love pushing through the systems. So I do that. So keep on, like, no is just the beginning of the conversation when it comes to benefits. So also I familiarize myself with if it's a managed care plan, I find out where the appeals process is. I've learned how to do treatment authorization requests, and service authorization requests. So when there's a way, I'll say to the doctor, oh, that got rejected. So how do we do a TAR or a SAR? I'm super familiar with the Department of Health and Children's Services Ombudsman's office. So you have to start with your local managed care plan. If you're fee for service, which is a different type of Medi-Cal, you go straight to the Ombudsman's office. There are also places, so those are all the kind of the places that I go to. But if you hit glitches, you should know that there are a bunch of committees, and I sit on one, the Medi-Cal Children's Health Advisory Panel, that are there to oversee how things are going. And there are organizations like Children Now, and there are organizations like NHelp that are there to help us help our kids. So I just never stop, if that makes sense. Like, if I know that my child needs that resource, and I've been told no so many times, and like, there's no one, it's shortages. They're like, there's no one there. We don't have anyone to refer you to. Just the other day, someone said, oh, we went over in September. And they're like, we're going to open the waiting list in July. And I was like, yeah, that doesn't work for me or my child, because, like, that's a lot of that child's life. So I said, so just humor me. Like, what would need to happen, like, to get a referral? And they're like, nothing. I was like, really? Like, if like a hand came down from the universe and said, like, I've got a magic wand, and it came out that there was a way to do it. Like, I could get an urgent referral. I could call my doctor and say, does she meet these 3 things? They're taking urgent referrals for this. And my doctor said, yeah, I think actually number 2 fits. I'll make an urgent referral for number 2. And it was like open sesame. I mean, so I know that was a lot of things, but there are a lot
really
of ways to
helpful
navigate
things.
this.
And I think we need to learn that no doesn't necessarily mean no. No means I can't help you because I don't know.
With the system, I think consent is different. No means no, like on our individual level, 100%, teach my kids that all the time. But when it comes to a gatekeeper for a benefit that our kids are entitled to, these are not privileges. These are entitlements. These are rights.
Absolutely.
These are civil rights. These programs were designed to take care of our kids. And so when I hear a no from a gatekeeper or someone who could provide a pathway for my child to get treatment, then I am like, no, it's just the beginning of our conversation.
I love that. I know that one of the areas that we run into oftentimes with these kids, mental health concerns, is you refer to mild, moderate, but our kiddos that have more severe needs. Unfortunately, at least my experience with how the state of California, what we have available for those kids is so limited. We have some emergency teams that can come out to the home. And of course,
Right.
if there's suicidal or homicidal ideations, then the child is hospitalized. Then the child goes to, a hold. And then if they're determined that they need more care, they go into a hospital setting, a mental health facility. But the ones that I'm aware of don't even have individual counseling. There's not a one-on-one. It's group settings. And what I've seen time and time again is the kids then get discharged and they're not any better.
Right.
And then when we look at where do we go from here? Now my child's been discharged from the hospital. Everything's supposed to be, wonderful now. And unfortunately, it's the same, if not worse. And then we have this repetitive cycle of these short-term hospital stays. And unfortunately, when you have kiddos who are your guardian or adoptive kids, your options are limited. Medi-Cal doesn't pay, at least my understanding, for these longer-term mental health residential facilities that can really do something more impactful than a week or two at these short stays. Do you have any thoughts on what we can do?
I do. Well, advocate, but short term, let me give you some ideas. So one of the things and I'm just going to say, one of my concerns with this that I have a lot of issues with is I feel like we're criminalizing an entire group of kids because right now there's an unfortunate connection between carceral systems and emergency behavioral health or crisis care. So I'm not going to I will refrain from my TED Talk on that topic, but I have a lot to say on it. But one of the things I think about, especially parenting a young person of color, is how at risk she is for having her behavioral health stuff criminalized or crises criminalized. So one of the things that I do think is a really successful model, I've got two resources. One is wraparound services. Now they're almost impossible to get, but are you familiar with wraparound? It's called California Wraparound. We call it WRAP for short. And the intent is to build on individual and family strengths to achieve positive goals and improve well-being. And the big focus is to use community-based resources.
I'm very familiar within the foster care system. I've had many, many, many wraparound, and I have my own opinions. I think wraparound is a wonderful theory if you have if you have qualified and experienced folks. I love the concept, and I have a WRAP team right now who, they are the A team. Absolutely love them. But I've had WRAP teams where, I have a unlicensed therapist who is under the supervision of a licensed therapist who really doesn't understand trauma. And it's been painful sometimes to watch the lack of therapy going on, and so yes, I have experience.
I so know that one. So, so I think, I think about WRAP. So the other organization that I love is, I don't know if you're familiar with Home Within.
No.
So Home Within is a 501c3 nonprofit. I'm going to totally shell for them. They are amazing. So what Home Within does is it recognizes that especially youth who've been in foster care at any time have a need for continuity and really professional counselors. So they have a remarkable training program where they train about trauma-informed care. They talk about vagal nerve disruption and all the things that the whole continuum for where kids get disrupted and where the ruptures happen with their parents, right? And they train all their providers. And here's the great thing. They get licensed clinicians. They put them through training. And these clinicians volunteer a single slot into the future. And they're assigned to work with a foster youth or a former foster youth.
Wow.
So your kid can get just the best possible therapist. And they'll work to match. And now with all the changes in telehealth, they're all licensed, right? So there is tele available, but there's also in person, and your child gets matched and the relationships last for years. So one of the things I had concerns with is I had kids who had already suffered all these separations and all this loss, and they would get interns, and some were good and some weren't good. I was an intern, so I know it's, sometimes you do a good job, sometimes you don't do a good job. But I was really concerned about the disruption pattern. I was like, fundamentally, our kids, they've had ruptures with their families of origin. And I don't care for how long it is or what the circumstances are, it has an impact. And then we're asking young people to form trusted relationships with clinicians of varying skill levels. And then we're interrupting it. And then we're saying, now you need to go bond with another clinician. And then we're going to interrupt it again. Whereas people with a lot of resources and money are paying to have relationships that extend for years and years, right? With skilled clinicians with some specialized training. So Home Within is a nonprofit. It's national. You can call them anytime. And they have a lovely intake team, and they will interview your child. And the thing is, it doesn't stay with you as a caregiver. The benefit falls to the child. So it's really quite lovely. Right. And they're also aware that there's some mobility. So therapists will work. If a child starts in one county and ends up in another, they'll work to make sure the child has continuity. So that is one, I have to say, that is something that I am so incredibly grateful for. It's made a big difference in the lives of my girls to have really skilled therapists. So then when we bring in someone like RAP, the other thing that's pretty awesome is you've got someone who knows your kid really well. And so when you're putting together those crisis plans or those behavioral plans, you've really got someone who's like in your kid's court and really knows what's going on with their mental health. So I know that sounded like an ad, but it's a pretty amazing resource.
Actually, well, it worked for me because I'm going to call them. So you sold me. So you've referred about RAP team. Is it possible for a child who is adopted to get RAP?
Well, let me say yes. I've adopted my kids, and one of my kids is getting RAP. And I know other people.
So how did you do that? Because that's something that I'm not familiar with.
Yeah, I will tell you. And I also have friends in San Francisco who, same thing. I know like 5 or 6 families. So I didn't even know it was possible. Like, it's the best kept secret in this way, right?
Yeah.
Who knew?
Yeah, that's why we're going to spread the news.
Well, if you go to some of the legislation around AAP, Adoption Assistance Programming, you'll see there's a line that says RAP services. In the benefits list on the DCHS website, just by the way. I found that fascinating. I went there. But the way that I used it this time is I had a kid, and my oldest kid was in crisis, and we tried all the things. And so I called FERS, which I never remember what it stands for.
Family Urgent Response System.
Thank you. So we needed that. So we called. And now I'm not going to say it was super rapid response. I mean, we had the immediate, make sure that, the ceiling wasn't going to fly off the house response. And it took a long time. I shouldn't say it took a long time. It took some dedication from people on the ground and from me as a caregiver and from my daughter, who I just want to say, as a teenager, showed up and said, yeah, I need some help. And this is not the right way to express what's going on. Do you know?
Right. She recognized.
And so I did some education. I looked at some of the language behind FERS. I looked at the language from the AAP. I pulled out a few other things, and I said, I just want to suggest that, I'm not a lawyer, but I'm happy to get one if we need one. But it looks like to me that she's entitled to RAP. And I think it's not just foster youth who can get RAP. Technically, I think any young person who hits a certain kind of criteria can. But I pushed it, and I also talked about 1915B waiver and said, especially mental health care is, again, it's a right for kids who've been in the system, not a
But
privilege.
who were you having this conversation with?
The county. I was talking with county mental health.
County mental health. Okay.
And I just want to be completely transparent. The first time I totally failed. And so, didn't work at all. Called FERS again and just said, so you guys have, I was like, this hasn't worked. The first time we did this, it didn't work. And I said, and I drew a care map. And if you don't know about care maps, they're really remarkable. You can find out about them on Packard. I drew one that showed the 7 different places that we tried to get something beyond mild to moderate for my daughter's behavioral health needs. And then I had 2 slides. I showed them all the things with labels. And then I had the next slide had the circles with little red lines and slashes across them. And I said, and this is all the places that have said no. Wow. And I said, so time is kind of running out because she's going to be 18, not too distant future. And I'd love to give her some tools and resources before she graduates and she ages out. So I went back, I think it was my 3rd cycle with the county mental health team. And I just said, I'm never going to go away And I said, I know you're all doing the best you can. And I know I'm taking up a lot of your time, but I'm just going to keep coming back because my child and all children, especially children who've been in the system, deserve to get the care that they need. And when I became a foster parent, I agreed to be the guardian, and I agreed to uphold the benefits and the rights that my child had, right? When we're in that guardian position, we're there to protect our kids' rights. We're there to make sure they get their benefits. Like if your kid comes to you with WIC or comes to you with CCS, you make sure that stays in place when you're a foster parent. And I just was like, it doesn't change. So I found the statutes for former foster children under adoption assistance. I'm not shy about calling NHELP. I'm like, hey, what do you know about the right for fee for service or whatever it is? And I've been really lucky. I've been joking lately that I should put together a navigation guide on how to navigate behavioral health for Medi-Cal.
Sure.
But, right. But I think, because it's one of my favorite things is to figure out how to crack the system to make it work.
Well, you
for
have
our
me
kids.
interested in, I don't know anything. So this is awesome. I would love to see that happen. And a lot of the things that you're talking about, if I'm hearing really the message that you're giving is don't give up.
Don't give up and focus on wellness. The other thing I just said to the county was I said, you guys, I actually worked for public health. So I was in the next building over, but I was like, hey, here's the thing. I said, I know that we all came in to do this work because we believe in the wellness. We believe in the right to wellness for our kids. And some of our kids are more vulnerable than others. And so I'm going to do everything I can to help us figure out what pathway, what bridges do we need to make sure that not just my kid gets care, but then, you're going to have these, you're going to know these statutes, you're going to know these new rulings. And the next time you get a call from a foster mom or a foster adopt mom, you're going to think oh, I know how to get this kid care. So I really see being an advocate as forming alliances. And so I try to really, I focus on a couple things: chronic wellness, advocacy as a form of alliance building, and really the opportunity to educate, because I believe no one comes into county mental health or to a community health center with bad intentions. I believe that every single person who's working in those systems came in because they wanted to help kids and families.
Make a difference.
So I try to join at that level. I try to even when I'm frustrated, I try to remember that at a heart level, that's really part of the narrative, and that we need to recapture that part of the narrative, that we're here to help our kids do the best they can.